Hypertension Awareness Series, Episode 25. Good morning. Resistant hypertension, when 3 drugs are not enough. And this discussion will be based on the latest JAMA 2026 review, diagnosis and management of resistant hypertension. So what is resistant hypertension? Resistant hypertension is uncontrolled blood pressure more than 130/80 despite 3 antihypertensive drugs at maximum tolerable doses. The drugs need to include a RAS blocker, that is an ACE or an ARB, a calcium channel blocker, and a diuretic. And the second definition is controlled BP requiring more than 4 drugs. So you can have controlled resistant hypertension in patients whose BP is controlled but requires more than 4 medications for it to be controlled. That is also resistant hypertension. Why does this matter? And this is because resistant hypertension is not rare. It accounts for 12 to 18% of hypertensive patients, and it is strongly associated with stroke, heart failure, chronic kidney disease, and there is increased cardiovascular mortality. So the first rule is to answer, is this true resistant? Many patients are misclassified, what we call pseudo-resistance. And pseudo-resistance is caused by poor BP measurement techniques, white coat hypertension, where the BP is just high in the office, medication and adherence, and suboptimal dosing, low doses. So diagnosis of resistant hypertension requires you exclude those first. What is the pathophysiology? Resistant hypertension is multifactorial, and the core drivers include volume overload, and this is the dominant mechanism. Inadequate diuresis and excess sodium is the primary mechanism. Mechanism number 2 is aldosterone excess, even when the levels appear normal. There is also renal dysfunction, CKD. There is sympathetic overactivity and secondary hypertension, especially primary aldosteronism, renal artery stenosis, and obstructive sleep apnea. But most patients will have overlapping mechanisms. So the stepwise diagnostic approach. Number 1, confirm true resistance, and this is confirmed by home BP monitoring or ambulatory BP. You check for adherence and ensure proper technique. Step number 2, optimize the current regimen, and this is very critical. Many patients are undertreated. Ensure they have optimal doses. Please refer to the earlier post where I discussed antihypertensives and their maximum doses. So for ACE, ARBs, for example, losartan, you can go up to 100 milligrams. CCBs, amlodipine, up to 10 milligrams. For the diuretics, preferred are long-acting thiazide-like diuretics, chlorothalidone, or idapamide. These preferred over hydrochlorothiazide. Suboptimal background therapy. Inadequate doses can falsely label someone as resistant hypertension. Step number 3, screen for secondary causes, and especially primary aldosteronism is very common. Check for chronic kidney disease. Check for obstructive sleep apnea, and we also discussed this during the earlier episode on secondary hypertension. Step number 4, review the lifestyle and drug contributors, the hidden culprits that can raise the BP, like high salt intake, drugs that can raise the BP, non-steroidal anti-inflammatory agents, which are used a lot for pain, the diclofenac, naproxen, indomethacin, the serotonin, norepinephrine reuptake inhibitors, things like duloxetine, illicit drugs, cocaine, amphetamines, alcohol, obesity. All those are hidden culprits that can raise the BP. So assess the patient's lifestyle. Management. How do we manage? Step number 1, optimize diuretic therapy. This is foundational. Volume overload is central. So the preferred drugs are thiazide-like diuretics, chlorothalidone, or idapamide. These are more potent and longer acting than hydrochlorothiazide. So optimize diuretic therapy. Step number 2, add mineralocorticoid receptor antagonists, and your number 1 choice is spironolactone. You use doses 12 to 25 mg and you titrate up to 50 milligrams once a day. It is the most effective add-on therapy and works even without obvious aldosterone elevation. You need to monitor your potassium and your renal function. The other alternative MRAs in the new update is amylolide. This has been included as a valid alternative, and you start with 5 to 10 mg up to 20 milligrams. This has similar BP reduction to spironolactone. It is better tolerated and has less gynecomastia. It is especially useful when when spironolactone is not tolerated. Other additional options include your beta blockers. Also put them on maximum doses. You can use your alpha blockers like doxazosine. You can also use your central agents like clonidine can also be used. And these add-on drugs are tailored based on the patient profile. Step number 5, treat the underlying cause. Treat the underlying cause. If the patient has hyperaldosteronism, you have targeted therapy, the MRAs or surgery. If there is obstructive sleep apnea, you can use CPAP. Renal disease, optimize the treatment, the pillars of renal disease treatment. Number 6, lifestyle is powerful therapy. In all these patients, lifestyle modification, salt restriction is very key. Weight reduction to target, regular exercises, alcohol reduction, and this can reduce the BP significantly. There are other emerging therapies that can be used. We have renal denervation, and this is catheter-based procedure targeting the renal sympathetic nerves and can reduce the BP in selected patients. So consider this in true resistant hypertension despite optimal therapy. So what are the clinical pearls from this review article? Resistant hypertension is often due to undertreatment, not treatment failure. Volume overload is the most important mechanism. Aldosterone plays a key role even when the labs are normal. Spironolactone remains the gold standard add-on. Amylolide is now a strong alternative, and always rule out pseudo-resistant first. So what is our take-home message? Resistant hypertension is not just about adding drugs. It is about correct diagnosis, mechanism-based treatment, optimize existing therapy, address lifestyle and secondary causes. Resistant does not mean impossible. Even when the BP seems stubborn, there is always a pathway to control. Remember, with precision, even the most difficult blood pressure can be controlled. So for resistant hypertension, rule out pseudo-resistant, check for secondary causes, check for hidden culprits that can trigger, stepwise optimize your diuretics, add on your MRAs, and then the other add-on medications for the patient. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.